Hi, I'm Tim Wiedrich, Section Chief for the Health Resources and Response Section of the North Dakota Department of Health. And this is our statewide hospital tactical meeting. We meet the second and the fourth Wednesday of each month, and those meetings are held at 2 p.m. At those times. This is a jointly sponsored meeting with the North Dakota Hospital Association. Tim Blazel, I don't believe, is able to be with us today, but let me just check and see. Tim, if you're with us, go ahead and unmute your microphone. I was not expecting him today, and so it looks like that is, in fact, the situation. So we're going to just go ahead and jump right on into the agenda for today. Dr. Connell is with us and is prepared to have some discussion about the monoclonal antibody treatments and its current status. Dr. Connell?
And I don't have any new news. I just need to reiterate the recent news of the recommendation to not use bamlanivimab by itself, but using it with its NDDoH partner in combination therapy, or use Regeneron, which is also a combination of monoclonal antibodies. The reason we're using this combination approach is because we're seeing resistance with some of the mutant strains of COVID, and we're seeing a greater percentage of mutant strains making up the population being infected. So again, if you have bamlanivimab in your facility, go ahead and order its partner drug and administer them together as they're indicated. Do not use bamlanivimab alone. And I'm happy to address questions at the end. Thanks.
All right, and I'd also just like to also reemphasize that if in fact you have a patient that's a candidate for use of monoclonal antibody treatment, but you're not familiar or aware of where those resources are locally, please reach out to our Emergency Operations Center. The Department Operations Center is available 24 hours a day, 7 days a week, and that is at 701-328-0707, and we will assist you in finding appropriate sources or resources for your patients to leverage the treatments for monoclonal antibodies and hopefully prevent hospitalizations. Well, let's go ahead then and move on into the hospital intelligence update, and Grace is with us to provide that information.
Good afternoon, Tim. Can you hear me?
Grace, your audio is muffled currently, and just speak a little bit more. Let's see if it's straightening out.
Okay, can you hear me now?
Clear as a bell. Thank you.
Okay, perfect. All right, so I will share my screen. Please let me know once you can see that. All right, do you see my screen, Tim? I can't see you anymore.
Yes, it is in now.
Okay, perfect. Thank you. So I'll just get right into it. So for the week of April 27th, we had a slight increase. We had a slight decrease in the number of tests that were conducted from the previous week, where we had 30,157 tests conducted. The week of the 27th, there were only about 29,770. Our 14-day rolling positivity did decrease from 4.72 to 4.44. So that's a bit of a positive. And then, of course, this translated into fewer cases being detected that week compared to the previous week. Our hospitalizations have been as high as 46 on April 21, and as of the 27th, they were at 35. And so overall, we do continue to see this sort of like variability, not so much of a consistent trend in terms of the number of people who are being hospitalized. But the good news is it has remained fairly low, and so we'll just continue to keep watching that trend. And then in the past month, we've had 17 deaths reported, but overall in the last week, we didn't have any new deaths reported. And so the recommendations that we brought forward, it was last week, actually, not this week, was really one to support the performance of whole genome sequencing for hospitalized cases. And I think this is mostly because we definitely want to know how much of our hospitalizations are attributable to the variants. And then really being able to know if they, we have hospitalized cases due to variants, that would actually lead us to being able to better understand what variants are circulating in the state currently. And then, of course, outpatient therapies, Dr. Connell is always thorough about that, so I'm not going to touch on that. And then with the vaccine, the fully vaccinated and non-fully vaccinated individuals, there are new guidelines coming out by the day. I think yesterday there was some guidance around, going to restaurants in outdoor spaces for fully vaccinated people, that they can do that without masking. So really staying on top of these recommendations from the Centers for Disease Control and Prevention will continue to be always a good idea. And then for the vaccine, and I think Molly is on the call, so she may be able to cover this better than I would. But again, convenience seems to help in terms of getting people, to show up and be vaccinated. And so looking at, schools, diabetes prevention programs, WIC centers, places where, your high-risk individuals may be gathering, or really at this point for us to build community immunity, it really needs to be anyone and everyone who is eligible for vaccine just getting vaccinated. And then as we sort of move forward with the testing numbers continuing to decrease, because that really has been a fairly consistent trend at this point, we're working very hard to identify the correlation with the wastewater surveillance and being able to extrapolate that information into meaningful results. So for example, if we can tell, from the levels of the RNA that we're seeing in the wastewater, that, this is the expected number of cases that would be in this population, I think that's going to be really valuable information moving forward, because as fewer people get tested, or as, people start doing in-home tests, if that, becomes a strategy in North Dakota and they fail to report to the state, then we would still have a pretty solid idea of what's actually happening at the population level. And getting right into the data, so this is just the numbers for the testing. As I mentioned, we did have a slight increase. And then for our positivity, we are, I think my data is a little bit older than what you're seeing here, but at the time we pulled these data, the positivity rate was at about 6%. And then in terms of where our new cases are coming from, so this has remained again fairly steady, I would say, in terms of our geography. Overall, Cass County, Burley, Ward, and Grand Forks continue to lead the charge in terms of the new cases that are coming up. But I would just like to highlight that, we do seem to see cases sort of all over the place. And as we know, this is a highly transmissible disease. And so when you detect one case, the chances of there being more in the population, like say, for example, Rolette County with the one case, are pretty high too. So the assumption would be it's not just the one case in that county based on how fast this can be transmitted. And if it's the case of, say, the new variants, those are even more highly transmissible. And so you do expect to generate newer cases over time. And again, this just goes back to the utility of the wastewater data. So if we can find a way to really make that data useful, it can really tell us more about what's happening, whether or not we have new cases being detected or not through testing. And then what you have on the top right is the distribution of the age of our new cases, active cases, sorry. And as I've mentioned in the past, really our younger people, and especially that younger adult population, seem to be the primary driver. And then when you look at the bottom right, where you have your hospitalization age distribution, the 60 through 69 age group does seem to have the highest number of cases hospitalized currently. But overall, from 20 through 29 to 50 through 59, you still see, that's 6 individuals. And so the messaging around, vaccines, outpatient therapies that will never get old for as long as we're still seeing people and younger people being hospitalized. Not that, it doesn't matter for older adults, but really across the lifespan, we don't want anyone hospitalized for COVID if we can prevent that. And then just looking at the underlying conditions that are driving some of the hospitalizations, and this data is about a week old, but the trend has remained fairly steady over time. Our hypertensive and diabetic adults do seem to be the people who are driving a lot of the hospitalizations. A majority of the people hospitalized have either one of these conditions. And so, again, that's obviously a population that's at high risk of mortality in the first place. And so COVID doesn't really help the situation. And so whatever messaging you can do through your, I don't know if there is, cardio programs or hypertension programs or diabetes programs to get these people in and vaccinated. And if they do have symptoms, to really get tested and go see their doctor for outpatient therapies, that would go a long way in really preventing that severe morbidity. And then I wanted to put this slide in here because one of the things that's happening, and so what you're looking at here, this table has the first column is just the months, and then the second column, which is what I'm hoping you can pay attention to, is the time to hospitalization. And what we're finding, so the time to hospitalization is an average. So these are the average days between diagnosis to hospitalization. And what you see over time is, from March 2020 through about I would say November of 2020, that between 2 and 3 days seem to be the average of the time it takes from when you're diagnosed to being hospitalized. We did have a bit of an odd thing happening in December, January, and February, where it was more like a lot more days between your time when you're test positive to when you actually get hospitalized. But in the last 2 months, what we've been seeing is a very short time span between your diagnosis and your hospitalization, which to me is an indicator of people are really not getting tested in a timely fashion. And so by the time they do test positive, they're already too sick and may actually miss the window of getting that the outpatient therapies. And so whatever we can do, I think along with the vaccine messaging and all the other messaging that's going about, it's still just as important to get people tested because, again, that will help keep people out of the hospital if they can be tested in a timely fashion, get their outpatient therapies. And then for the rare cases who do need to be hospitalized, then that number would be smaller over time. And then in terms of wastewater surveillance, we do continue to see a decline, not really declining trend. I think it's kind of all over the place, but overall, we still are in the yellow zone for most of these cities. We do see a bit of an increase in Williston, Watford City, I want to say Minot and Harvey. So maybe I lied. It is actually an increasing trend in quite a few of these cities. But overall, the state continues to be under the sort of that dark yellow zone. And what I've always said is if you look at when we've been at our worst, which is the October through say December of 2020, it kind of gives you an indicator of how much worse it has been. And so we're not at zero. We still have the virus circulating in our wastewater, which means it's circulating in the state and amongst our populations for all these areas, and of course more that are not sampled. And so this is not a time to relax and not do due diligence, because truly we still have COVID in the state. And then looking ahead. So what you have in the orange is our projected values, and then the blue is our actual active cases. So we do expect that this will continue to increase over time. And as I've always said with models, essentially what you're doing is you're modeling the future based on current behavior. And so we've had a bit of a plateau in our vaccine uptake, and I'm hoping that will slow down. Well, the plateau will slow down, so that means our vaccine will actually continue to increase, because again, that's what's actually going to change the trajectory of this curve in our projection and also in our actual cases, because the more people vaccinated, the less opportunities for transmission that will happen in the state. But overall, based on our current behavior as a state, these are projected values. And then these are just the same for active hospitalizations. They follow a similar trend to the active cases. And what I find interesting is our model is actually underestimating, again, the number of new hospitalized cases, but not as significantly as previously. But we do expect that this will continue to increase if our current behavior remains. I think that's the key takeaway here. And then this is just our vaccine coverage. I don't know if Molly already gave her update, but I am not going to get too much into this. But overall, we do continue to see increased uptake. And I believe as of yesterday, I think I saw that release from the CDC where over 50% of the state has had at least one dose. And so, kudos to the team, but I really do hope that's an ongoing trend, because if we can continue to go on a projected values, then truly that would change the entire trajectory of my curve of predicted values. And then people will actually think that I don't know how to do my job because I was wrong, but it's really because we changed our behavior. So that's really all I have for today. Thanks, Tim.
Thanks, Grace. Let's go ahead and move on to the next topic, which is the hospital data reporting. As many of you will remember, we are submitting data to both the state and the federal governmental requirements for hospitals through a single system, and that's meeting both needs. We had some recent changes, including some of the support that goes towards that and some additional questions that have been recently added. Normally Ryan Dreher would be appearing with us today, but he's on the road, and so Angie Strand will be filling in and giving us some of the information about the current status of the hospital data submission. Angie?
Thank you, Tim. I don't have too much of an update, but from information that I've received from both Cody and Ryan, there should be a new FAQ guidance document coming in about a month, as well as discussions about the amount of questions and frequency in reporting internally. Additionally, there might be a reduction of questions and or frequency of reporting at some point in the near future. Cody doesn't see it to be too drastic in a change or too much of a change, but that's what I have from both Cody and Ryan today.
Great, thanks, Angie. And then just as a reminder to the hospitals that technical support for the hospital data submission is available to you 24 hours a day, 7 days a week. And again, the way you access that is through contact with our Emergency Operations Center. The Department Emergency Operations Center phone number is what was displayed before, 701-328-0707. So if you run into a technical issue with submitting data, don't hesitate to reach out to us. We're happy to assist. Well, the next topic is the testing update, and Nikki Brunell is with us for that topic. Nikki?
Thank you so much for having me. Just wanted to give a little update. So currently there are a few rapid antigen tests that can be purchased over the counter by individuals. And because this is a screening tool and not a diagnostic test, we would not, as the state, be recording that result as a definitive diagnostic test. We have had some people call into the hotline to report their results, but however, since we are not present, we are not watching to make sure the test is performed correctly. If they are positive, we are recommending that they follow up with their primary care doctor to verify their results with a PCR test. And if they are symptomatic and have a negative Binax, they would have to also follow up with their primary for verification. So these are being distributed out to the different pharmacies. I think they range anywhere from 20 to 25. But if any of the hospitals do have any of their patients call in, just to inform them that they would have to do a follow-up PCR test. The other thing with the rapid antigen test over the counter, we have no way of giving them a report on their result. So in order to do that, they would have to have a PCR test or have a rapid antigen test performed at one of the testing sites. So if anyone has questions, please feel free to reach out to us. We are going to be putting an FAQ sheet together that Tim will be sharing with everyone, but just kind of a heads up that they are out there, and we are starting to get calls about people wanting to report.
Thanks, Nicole. Molly Howell is with us with the immunization program, and so Molly, what information do you have for us?
Sure. Good afternoon, everyone. So I have a few things. As Grace mentioned, according to CDC's vaccine tracker, more than 50% of North Dakotans ages 18 and older have at least started the COVID vaccine series. So we can now say that the majority of North Dakotans have accepted COVID-19 vaccine, which is great. However, there is a lot more work to get done, and probably even potentially the harder work, especially addressing those who are more passive about immunization or those who have some vaccine hesitancy. I think so far we've vaccinated the people that have really come to us and been interested in vaccination, and now we have to work to make vaccine more convenient, which you can definitely help with in ensuring vaccination in the emergency room settings, urgent care, at various specialists, whether that's OBGYN, dialysis centers, and then clinic-based vaccination. And at the very least, if you can make sure that all of your physicians are talking and making a recommendation to every patient to receive COVID-19 vaccine. Most studies find that really it's a physician recommendation that patients want to hear when it comes to making a decision around vaccine. The Johnson & Johnson vaccine, as many of you know, was put on pause a couple of weeks ago. The Advisory Committee on Immunization Practices met last week and discussed the pause. 15 additional cases of thrombocytopenia with low platelets have been, or 15 total cases, not additional, I should say, have been identified in the United States after J&J vaccination, all in women, most of them under the age of 50. And the ACIP did look at a lot of modeling data and really determined that vaccination with the J&J vaccine will prevent more hospitalization and death over potentially causing these blood clots. So, for example, by resuming vaccination of people 18 and older, it may cause 26 cases of thrombocytopenia in 9.8 million vaccinations. However, it would prevent 1,435 deaths and 2,236 intensive care unit admissions. So vaccination, even with the J&J vaccine, continues to be of more benefit than potentially getting COVID-19 disease. I do think it's important, though, to note that you should inform your patients of the risk, and the FDA emergency use authorization fact sheets were updated to reflect the potential link with these blood clots. And I would counsel patients, especially women between the ages of 18 and 49, as to their risk and what potential symptoms they should look out for. And then even if you're not administering J&J vaccine, I would make sure your providers have our health advisory regarding blood clots and how to potentially treat these blood clots, as heparin should not be used. And so we did send out guidance as to what the treatment is for these blood clots. And so if you see someone that you're suspecting blood clots, you'll want to ask about a history of Johnson & Johnson vaccine in the previous 3 weeks, and then treat accordingly, and of course report to the vaccine adverse events reporting system. I also wanted to mention a couple of CDC MMWRs that were released since the last time we chatted. Just today, CDC released an MMWR showing that the two mRNA vaccines are 94% effective against hospitalization for people 65 and older. And even partial vaccination was 64% effective. So more and more good news on the vaccine front, and these vaccines definitely do work. And then, of course, there was a study last week that was published also in MMWR regarding an outbreak at a long-term care facility in Kentucky, where an unvaccinated healthcare worker did bring COVID into the facility. And unvaccinated residents and staff had 3 and 4.1 times the higher risk of infection, as did those who were vaccinated. And so vaccination definitely does prevent COVID. And even if we do have breakthrough cases, they are appearing to usually be more mild or asymptomatic. On the breakthrough front, North Dakota has reported 226 potential breakthrough infections. That is less than 1% of North Dakotans who are fully vaccinated. And so this vaccine is working, and we're not seeing anything out of the ordinary in terms of what we would expect the effectiveness of these vaccines to be. Also, you may have seen in the media some concerns about people not coming back for second doses. In North Dakota, 9,293 individuals are 42 days past when they received their first dose. And so that's less than 4% of people who need to have 2 doses haven't come back. And so the North Dakota Immunization Information System does have reminder recall functionality that I encourage you to use to recall individuals that you gave first doses to who had not come back for second doses. Also on the pregnancy front, hopefully all of your OBGYNs are discussing COVID-19 vaccine with their patients and recommending COVID-19 vaccine. There was an article published in the New England Journal of Medicine showing the safety of COVID vaccination in pregnant women. So I urge you to take a look at that. And please make sure OB is encouraging vaccination. And then we are starting a new campaign that you will see out on social media, billboards, gas stations, TV, radio. And it's really more aspirational and focused on the benefits of vaccination. And it's called Let's Get Back Together. And it's really about how we can all get back together, but do it in a safe way, which is through vaccination. And we're using imagery from North Dakota, including we're partnering with NDSU and UND to hopefully get some younger individuals vaccinated. Going to the state fair, going to Medora, traveling again safely is what we all want to get back towards. And then I just briefly wanted to mention House Bill 1465, as that may be in the media today. An amendment was passed by both the House and Senate today, which does prohibit the state government or any subdivisions from requiring documentation of vaccination. But I do want to mention that it does exempt healthcare facilities and long-term care. And it also does exempt private businesses in terms of their staff. And so you can take a look out at that bill on our legislative site. And then just thinking into the future, it's likely that the Pfizer, at least COVID vaccine, will be available for adolescents ages 12 to 15, in addition to the 16 and 17-year-olds right now. And so you'll want to be thinking about incorporating family practice and pediatrics into COVID vaccination efforts and making sure they're able to communicate about the vaccine. And because this vaccine cannot be administered with other routine immunizations, you'll really want to be thinking about how you're going to space out COVID vaccine and routine vaccines 14 days apart. Which one are you going to give first? And if you are scheduling them, like for example, if you give them their COVID vaccine, please make sure if they're due for routine immunizations, you're checking that and you're scheduling them 14 days later for their routine vaccinations or vice versa. My other ask would be, again, just to make sure you're making vaccine convenient in your local areas and convenient at your facilities. So any patient that enters your facility, they're at least having a conversation about COVID vaccine and being offered COVID vaccine at that location. Otherwise, I will turn it over to you, Tim.
Thanks, Molly. And if you have questions, we'll be coming to the question and answer period shortly. But first, we're going to want to have a brief conversation about the status of PPE in the state. And for that, we'll go back to Angie.
Thank you again, Tim. Can you hear me okay?
I can hear you fine.
Perfect. Okay, so the cash is pretty much being sustained very well at this time, thanks to the supply chains opening up a little bit more than what they were when we were in full swing of the COVID response. Everything besides the N95s are sitting at or above pre-COVID numbers at this time. Once we received the 2 open purchase orders that we have for the N95s, we should be sitting right at where we started at, 1.6 million for the N95s. So for N95s currently in the cache, we have 1,019,080, and there were 17,940 of those issued within the last 2-week O period or operational period. For surgical masks, we're at 2,757,000, and there were 10,150 of those requested and issued out within the last 2 weeks. For shoe coverings, we're sitting at the same 20,786. There were 0 requests for those. For isolation gowns, we're at 1,773,016. Forgive me, they're putting in something just right outside of my office, so I'll try to be louder. And for issuing the gowns within the last 2 weeks, there were 700 requested and sent out. For gloves, we're at 5.1 million, and there were 47,050 sent out. For face shields, we're at 1.1 million with 420 sent out. And for goggles, there were 0 requests for those, and we're at 22,415.
Thanks, Angie. It sounded like you had a very radical woodpecker just outside of your office there. And so our apologies for that. The same thing's happening here in the studio. We're having some construction around this office area. We do have the VP3 team with us today, but there's no update, even though they're very active. There's no report for today. And so that brings us up to the hospital rounds or the question and answer period. If you do have a question, this would be the time to go ahead and unmute your microphone and state your question or comment. Well, people are thinking, Molly, I'd like to go back to you for a moment. I know that we've had a lot of conversation with long-term care about what are called breakthrough cases. But for those that aren't terribly familiar with how we're defining them and how we're, what that consists of, can you just give us a little bit more explanation about what we consider a breakthrough case?
Sure, Tim. A breakthrough case of COVID-19 would be someone who's fully vaccinated, so either 1 dose of the Johnson & Johnson vaccine or 2 doses of the Moderna or Pfizer vaccine, and is 2 weeks past their last dose, and then goes on to develop COVID and test positive through either PCR or antigen testing, is how we're defining a breakthrough infection. And so we are finding a lot of our breakthrough infections, some of them are previous positives, and so we're a little unclear if they're still testing positive from their previous infection, or if this is a new infection, but we are still counting them in our breakthrough case count. We're also finding a number of them are either asymptomatic or have very mild infections, which is good. But we would like providers as much as possible if you can do or submit a specimen for whole genome sequencing, because we do want to better understand if our breakthrough cases are due to variant viruses or due to the more traditional viruses.
And because there's so many variables that are associated with this, they really end up being treated on a case-by-case basis between the provider and disease control. Is that right, Molly?
Yes, that's correct, especially in the long-term care setting.
Yeah. All right. Well, let me see now. Do we have anybody that has a question or a comment?
Tim, Rick Litzinger.
Go ahead, Rick.
Emergency manager at Ultra. Got me? Okay, good. Quick question. Knowing that the declaration is ending for the state on Friday, and also the extension of the public health emergency at the federal level to, I believe, July or June, through Health and Human Services, if I read that right. I know there was an FAQ that was sent to internal Department of Health sections, also local public health partners that identified public health, schools, and that realm, but I don't recall anything sent out to the hospitals. And I guess from a declaration standpoint, our surge plans have triggers that depend on declarations and capabilities within that, like cohorting certain things. And just wonder if we need to amend those plans, or with the federal declarations still in place or extension, are we able to still go off of that, or do we have to adjust those plans? And I guess second of all, with the Unified Command going down, I know there's still some National Guard involvement on the testing sides and teams across the state. what does the structure look like? I mean, I'm pretty familiar with it, but I just want to make sure that all the hospitals are familiar with it too, and get that information when this transition happens on Friday, just so it's streamlined and we're aligned, because you go across the river and 25% of the ICU beds in the state of Minnesota are filled with COVID patients. So, and they're really booming over there. They're down a little bit from last weekend, but, eastern part of North Dakota was receiving patients from the Critical Care Coordination Center last Friday. So, and we're tight in general. So we're just kind of making sure that we're aligned from a communication standpoint and making sure we're not overstepping bounds or just streamlining, so we have a quick communication if we need to pull some triggers over here.
So thanks for the question, and I'll take first stab at it and then see what the rest of the panel has to contribute. So in terms of the state declaration ending, basically it's been our assessment that in terms of the core response activity and in terms of the funding that we're receiving, those types of issues are not impacted at all. We are not seeing any difficulty in terms of the steps that need to be taken in order to ramp up our response, if in fact that becomes necessary, nor are we seeing anything that is lost through this removal of that state declaration that would cause us to withdraw or tamp down our current levels of response. What's being reflected really is just a transition as unified command is ending. And for those that aren't familiar with that term, basically it's an emergency management process that we shifted away from normal kind of core activities of state and local public health into a more whole of government that had the governor's office, the Department of Emergency Services, and the health department that were co-managers of that in the form of a unified command, but now transitioned back to the state health department in terms of that state role and leading that effort as we normally would with other forms of disease outbreak or public health emergencies. And so while that transition is occurring, the types of major activities are going to continue on just under the infrastructure what would normally be in place with the state health department. So again, we don't see this as a curtailment, so to speak, or withdrawal of the response activity. Specifically relative to the National Guard, obviously the National Guard, as this has ebbed and flowed during this past year, has had varying levels of involvement. Their principal involvement right now centers around a lot of support to local public health. That is not ending as a result of the April 30th end to the state health or the state emergency declaration. So their current level of National Guard involvement will continue. It will continue to be there. But these transitions are in fact occurring to the state health department for the roles that we would be normally carrying out, and just as we are proceeding, we're not seeing any detriment to the issues of our response. It's not a stepping down. We still have major issues that we're continuing to face, and believe that we have the infrastructure around us and the appropriate processes to move forward. Rick, in terms of your comment relative to the emergency departments and ICU, obviously we are concerned about the numbers and where those numbers are going. And there has been a significant concern with some of our surrounding states and what's happening in our own state. Routinely now we're somewhere around 30 ICU beds that are available on a daily basis throughout the entire state. So it's for that reason we're still watching very closely the information that's being put in daily into Healthcare Standard and the hospitalization data so that we can track that. And so thank you for that data. That's what's giving us in part a situational awareness about the status of that. I may have missed something, but let me throw it open to the rest of the panel and see if anybody else has anything to add before I throw it back to Rick to see if he has any follow-on.
This is Joan Connell, and I guess I wanted to add a couple of things from my personal experience as a provider with regard to this topic. And that is since the declaration, and especially since our local schools have changed their plans and are getting rid of their mask mandates. I've had several families with kids with vulnerabilities, including asthma, reach out to me requesting a letter to support their children being able to be online schooled due to the perceived increase in risks. So I'm readily providing those letters to my patients who meet risk criteria. But I want you to be aware that that might be something that may be require quick attention from your providers over the next few weeks.
Thanks, Dr. Connell. Rick, any follow-on? Thank you for those.
No, I think the biggest question, Tim, was just the two declarations and just understanding the scope, I guess, and you covered it. It's kind of business as usual from the emergency management side as it pertains to our surge plans and I guess all of our operations, really, that anything that, like the waivers, anything that's dependent on declaration is still in place is kind of what I gather, right?
Yep, that's our assessment.
Thank you. Yep, no, that's good. That's all I got.
Thank you for that. Any other comments or questions at this point?
This is Dr. Connell again. I had one comment to build on what Nicole Brunel was saying about home testing. And I thought she had a nice illustration that she shared with me that I wanted to pass along. For any of you who have performed the Binax test, you'll see that it needs to be read within 15 to 30 minutes of administration of the test. And so she had a couple of patients who read their results an hour after starting the test, and they went from negative to positive. PCRs were performed to confirm that they were negative, as well as rapid antigen tests, which came back negative as well. So, so don't have any hesitation in affirming those positive tests that are done at home and unsupervised.
Thanks, Dr. Connell. All right, any additional comments or questions? Well, hearing none, I just want to remind you that we'll be back again on the second week of May. We're meeting the second and fourth weeks of each month on Wednesdays at 2 p.m. These programs are archived, so if you need to go back and want to see an earlier program, you can always find them at this location. Take care, everybody.